Welcome to Manchester Hip Arthroscopy. This is a presentation on soft tissue hip surgery by Mr. Max Fehily, Consultant Orthopaedic Surgeon at the Royal Bolton NHS Foundation Trust and Manchester Hip Arthroscopy. Patients present with hip pain a variety of ways. The most reproducible area is in the groin, but they can also present with pain in the buttock, the lateral hip, down the anterior thigh, or even the front of the knee. And when you see these patients, you must always think in your mind, could the source of their pain be extra-articular or intra-articular? When you do an examination of a hip patient, you must do a thorough soft tissue examination. And so look in the areas of the groin, the insertion of sartorius at the anterior superior iliac spine, the insertion of the adductors, the trochanteric area, and the sacroiliac joint. I always do a hip impingement test, i.e. flex the hip right up with internal rotation and adduction, and also the McCarthy extension test looking for psoas irritation. If necessary, I'll even consider doing a joint injection using either pure local anesthetic or in combination with steroid. Radiology, I always get an AP hips with marker because that allows me to compare the two hips, and I use the marker because some of these patients will have considerable OA and so need a hip replacement. I order a lateral hip with 15 degrees of internal rotation so that I can easily visualize the front of the femoral head-neck junction. I'll order an MR arthrogram, which will allow me to look for any soft tissue abnormality within the joint. And more recently, we've been using CT scans with 3D reconstruction because these are far more accurate in assessing the abnormalities of the femoral head. I'll occasionally use a dynamic ultrasound when looking for an abnormal psoas. So there are a number of causes of intra-articular hip pain. The most important from the point of view of this talk is hip impingement, and that can either be a bump on the front of the head-neck junction or a pincer impingement due to an overhanging cup. There'll often be an associated labral tear or chondral damage, but there are other causes such as loose bodies, avascular necrosis, PVNS, ligamentum teres tears, stress fractures and OA, and all of these can occur in hip arthroscopy patients. The most common cause is due to impingement, and you can see from this photograph that this patient has a concave posterior femoral head neck but a convex anterior, and this is the cause of their symptoms, and we call this a cam impingement. The patients will often present with groin pain worse on deep flexion. They'll have a positive hip impingement test, and they may well have an associated labral tear, and if they've had their symptoms for some time, they can have an associated psoas snapping, adductor tendinitis, and trochanteric bursitis. And this is why these patients can be confusing if you're not used to looking at hip arthroscopy patients. This is a schematic representation of what hip impingement is. So the top two diagrams are a normal hip, whereas the hip flexes up. The acetabular rim sits in the concave surface. The second row shows pincer impingement, where there's an overhanging or an excess of the anterior rim, and as the hip flexes up, it catches. Or the lower row is a cam impingement, where the abnormal bump bashes up against the anterior rim as the patient flexes up. This is an animation from primal pictures showing the cam impingement. As the patient flexes up, this bump catches the superior labrum. It's often a war of attrition, and repeated flexion and extension eventually causes that rim to peel back, and as the rim peels back, it exposes the chondral junction, and this then starts to peel down. And so most patients, in my experience, don't present with an acute injury. It's a slow, steady progression with increasing symptoms. The next cause is pincer impingement, and as I said before, this is due to either an overhanging anterior rim, or in some patients the whole acetabulum will be abnormally positioned and usually retroverted. It has a similar effect. As the normal head neck comes up, it bashes off the rim. Repeated injury can often cause shredding of the labrum or even ossification. and again is a similar effect on the chondral surface of both the anterior aspect, but also they can get a contre-coup type injury posteriorly. It's important to use both the plain x-rays and the CTs to assess whether patients are a CAM type patient or a pincer impingement patient, because they have quite different surgical treatments. When I first started, we did a number of open hip debridements, and this was used in the well-known Gantz or Bernese approach. The trochanter is detached, the hip is dislocated, and the head is then refashioned, and it also allows you to deal with any labral abnormality. Obviously, this is a significant procedure with considerable rehab, and that was the reason for moving into hip arthroscopy. This is intraoperative photographs showing the CAM on the left and then the patient post-resection on the right. But it's a nice picture to allow visualization of the abnormality. This is a video of a hip arthroscopy. That's me probing the labrum, and it shows the fraying at the labro-acetabular junction. This patient did have hip impingement, but the labrum itself was quite solid. And in my experience, only about 10% of labrums need to be repaired. So other causes of pain aside from impingement, well, as we previously mentioned, they can often have chondral damage, particularly if the problem's been there for some time. Their symptoms do change, and so they'll start to get increasing deep groin pain, and it will start to become mechanical in nature, so they'll get increased pain on loading and exercising, and they'll start to get pain in the morning with associated stiffness. Often these lesions are invisible in MR arthrography, mainly because the chondral flap is reduced by the presence of the femoral head, and it's only when the head is distracted does the flap come away. Current treatment is debridement with microfracture, but in the future there may well be a role for osteochondral grafting. There are other extra-articular causes, such as iliopsoas, adductors, sartorius, tensor fasciolateral and trochanteric bursitis, and these often all occur at the same time when patients have had symptoms for some time. If you rehab these patients appropriately, this surrounding musculature abnormalities will improve, and the patient will only be left with their groin pain. However, if you don't address that and they stop their rehab, these other pains will return. So, how do you do it? First of all, you have to create some access. There isn't a true cavity in the hip joint, and so the leg has to be put on traction. Once traction is achieved, a fine needle is inserted into the joint. This is a hollow needle, and the inner portion is removed and a fine wire placed over it, and then over that wire the instruments can be railroaded. These instruments are about 45 millimeters in diameter, and the X-ray shows how narrow this space can be.